This PowerPoint covers Chapter 17, 18, and 19 for Module 6. Chapter 17 is all about the principles of inflammation and immunity, and this should be a refresher back from A&P, if you had microbiology. So I'm not going to go through that in the PowerPoint. That's something that you should already have a pretty good base of knowledge in. So please make sure that you read through it, that you understand what is involved in inflammation, what cells are involved in immunity. And be able to speak to both of those things. Transplant rejection, or graft versus host disease. So graft is just another word for the transplanted organ, the donor that has donated a blood organ that's going into our patient's body, into the recipient's body. Because our bodies have specific markers for that recognize ourselves versus non-self, sometimes it's very rare that we get, especially an organ that is an exact match. Sometimes if the donor is an identical twin, then maybe it's an exact match, but for the most part there's going to be some differences. So it's not a surprise then that the body is going to recognize this as an invader and try to get rid of it. And there are three different kind of phases of rejection. The first one is hyperacute. So this happens like right away, within minutes of the new organ. Usually because the recipient's blood has these pre-existing antibodies. And remember, antibodies are what respond to the recognition of foreign antigens. So they have already got this antibody, and the antibody-antigen complex adhere to the lining of the blood vessels. They activate the complement, which triggers these small little blood clots to form in the new organ, and that doesn't work very well, right? It leads to ischemia, necrosis. The organ can't make it, so that usually then the graft has to be removed right away. This is pretty common in kidneys, but we do a better job of matching, so it's not quite as common. We can really kind of get into the blood and pinpoint what factors are there, so that we can have a more successful match. Acute rejection then happens within a week to 3 months after the transplant, and sometimes sporadically after that. It happens from antibody-mediated mechanisms, and then some cellular-mediated mechanisms as well. The cytotoxic T cells and natural killer cells come into the transplanted organ, start inflammation, and cause the cells in the organ to die. So the way that we tell if a patient has this is by doing labs, and they basically just show us that the organ is not working. We can also go in and take a biopsy of the donated organ. There's not just like one set of symptoms that we see with this. It kind of depends on which organ was transplanted, and even person to person can vary a little bit. But your book gives a good example of if somebody gets a kidney transplant in an acute rejection, they might feel kind of some soreness or tenderness over their kidneys. The third type is chronic rejection, and chronic rejection is just the result of this chronic inflammation, which leads to scarring. The smooth muscles of the arteries start to overgrow, and they end up occluding vessels. It's replaced with this fibrotic scar-like tissue, and so the organ, whatever organ, we have specific cells in each one. If they're replaced with tissue that's scar tissue that's hardened or fibrotic, they don't work as well, right? So in time, the organ becomes destroyed, and so a lot of time, I mean, there's no cure. We can't go back and change those fibrotic things that have occurred. So eventually, when the organ can't function anymore, the only thing that we can do is take it out and give the patient a new organ. Most patients that have an organ transplant have to take ongoing medication to prevent rejection. So we do something called maintenance therapy, and maintenance therapy is just this continuous immunosuppression that we use after we get a solid organ transplanted. They're usually a combination, so we usually give a combo of meds. We give corticosteroids, right? Corticosteroids can help to cause kind of general immunosuppression, but again, remember that it puts the patient at risk for infection. They're usually given in pretty low doses. We do calciurin inhibitors and anti-proliferative agents as well that specifically target different immunity components that usually cause rejection. It just kind of depends on what type of transplant the patient gets and the patient as far as dosing. But these are going to be lifelong. They're not going to be able to stop taking these meds. So an example of a calcineurin inhibitor is cyclosporine, right? An example of an anti-proliferative is Cellcept. So those are kind of some common ones that you'll see. And with both of those medications, I mean, they suppress the immune system in one way or another, so we do always have to be wary of infections. Additionally, cyclosporine can be nephrotoxic. It can lead to hypertension, coronary artery disease, different malignancies, hepatotoxicity, so they're not easy on the body at all. Cellcept can cause thrombocytopenia, malignancies as well, leukopenia. So again, lots of not necessarily enjoyable side effects. We also have rescue therapy that we can use to treat acute rejection episodes. And there we use the monoclonal and polyclonal antibodies. And they are used, we can also use some of our maintenance therapy meds for acute rejection, just at a much, much higher dose. In autoimmune disorders, the body begins to attack itself, its own cells, its own tissues. We're not really sure why this happens. There are a lot of theories, and it's actually a relatively new concept even that wasn't recognized in medicine until the 1950s, 1960s. So still relatively new. Since we don't know why this happens, they do have some ideas. So they think it's a mix between genetic predisposition, through hormonal things, dietary factors, environmental, and other external factors. But what happens basically is the immune system fails to recognize the body as cells or tissue as itself, and so it starts to break it down in various areas by self-killing cells, and this results in autoimmune disorder. One example of an autoimmune disorder that you'll see quite a bit in practice is rheumatoid arthritis. So rheumatoid arthritis is chronic, meaning that it lasts, it doesn't go away, it's not acute. It's progressive, so it gets worse. It's systemic, which means that it affects body systems. And it's inflammatory, and it's an autoimmune disease. So first, what is a rheumatic disease? A rheumatic disease is any disease or condition that affects the musculoskeletal system. Arthritis, then, is the inflammation of one or more joints. So with RA, it mainly affects the synovial joints, and there's this chronic inflammation of the synovial membrane. And just remember, the synovial membrane is the lining in all movable joints. And what happens is this chronic inflammation leads to swelling, it leads to pain, it leads to the erosion of joint cartilage and bone. Granulation tissue starts to build up, so the space between the joints changes physically and causes deformities, changes as well. It is more common in women, and it typically starts between the ages of 35 and 45. A lot of times we see it bilaterally and symmetrically. So, for example, both wrists, both shoulders. And often, too, it'll start with smaller joints, like the joints in the fingers, and then start to move into larger joints. So here's a close-up picture of a synovial joint, and you can see that synovium, or that fluid, is inflamed, right? It's kind of bulging out. It gets thicker, and it becomes hyperemic, you can see the fluid is accumulating, and then something called a pannus forms. And a pannus is this, it's a layer of vascular fibrous tissue that covers the surface, and that's what ends up wearing down that articular cartilage and ultimately destroying the bones. So with bone destruction, we have to think too that the patient might have some osteoporosis in time. So early on, what we see in our patients with RA is just kind of feeling generalized weakness. They're feeling tired. They might have a loss of appetite or anorexia. They can lose like 2 or 3 pounds. There's sometimes this persistent low-grade fever. And then they have the joints are inflamed. They kind of hurt. A lot of times it's the joints in the upper extremities that we see first, again, kind of in the hands. Later on, as the RA progresses, that's when we see the joint deformities. So you can actually see the hands get kind of gnarled. It can affect the wrists, the knees, the spine. The patient can have the pain becomes more moderate, sometimes even severe pain. We can see too they're really stiff in the morning, and so this morning stiffness, which is called the gel phenomenon, happens when patients get up, and usually if you're feeling sore in the morning, which is common for a lot of adults, especially as we get older, just feeling kind of sore or stiff. But in RA, they're sore for more than an hour. It goes on. It takes them a few hours in the morning to start to kind of loosen up. They also can get tired after periods of prolonged activity. They can develop in time osteoporosis, just severe tiredness, right? This is a systemic disease. It can lead to anemia, these subcutaneous nodules that we see. And we see these, a lot of times they're on the ulnar surface of the arm, fingers, sometimes over the Achilles tendon, and these can come and go. They're not always there. It can lead to respiratory and cardiac problems, and then it can lead to Sjögren's syndrome, which we'll talk about here in a couple slides. There's some different labs that we can do to kind of test for rheumatoid arthritis, but know that there's not just one definitive lab or even 2 definitive labs that'll say, yep, you have RA. Instead, these labs just give us probable cause, basically. So the first one is the anti-cyclic citrullonated peptide, or anti-CCP. And this is a newer lab. It's really, really sensitive. It detects antibodies to the cyclic citrullonated peptide. And is positive in most people who have rheumatoid arthritis, even years before the symptoms actually develop. It's more sensitive for RA than the rheumatoid factor antibodies, which is the second test. So the RF factor, rheumatoid factor antibodies, are positive in a lot of patients that have rheumatoid arthritis. About 80% of the people with the disease, and so. Usually between 140 to 160 is a diagnostic level for RA. Expected reference range is 1 to 20 or less. Other autoimmune diseases, though, like lupus, for example, can increase RF. And they can also, these higher rates correlate with the severity of the disease. We can also look at the C-reactive protein. And this one we can do instead of the ESR. It's really useful for diagnosing disease, but it can also monitor disease activity and for monitoring the response to anti-inflammatory therapy. So it's just a marker of inflammation in the body. It's pretty sensitive. And then ESR is the erythrocyte sedimentation rate, and an elevated ESR or SED rate is associated with inflammation or infection in the body. So usually between 20 and 40 is mild, 40 to 70 is moderate, 70 to 150 is severe inflammation. And note too that SED rate doesn't say what is inflamed, neither does CRP. They just tell us that inflammation is present somewhere in the body. We can do ANA titers as well. ANA is the anti-nuclear antibody, and that's just the antibody that's produced against your own DNA. So we see it in these autoimmune diseases. A positive ANA is associated with RA. But again, other autoimmune disorders can increase ANA. For diagnostic procedures, we can do x-rays, we can determine the degree of joint destruction, monitor progression. It can really give us a good picture, right, and reveal any bony erosions. When the joint spaces become narrowed, we can see that too. It actually negates the need for really expensive radiological tests like CT scan or MRI, although sometimes you do still do a CT scan, particularly if the spine is being affected. And then an atherocentesis as well, which is where they can aspirate or remove a little bit of the synovial fluid by inserting a needle in. And what we would see then when they analyze that fluid is the presence of white blood cells. When we're talking about interventions for rheumatoid arthritis, our focus is to minimize pain in our patients, and it's chronic. Most of the time, there's going to be some level of pain, but we wanted to get it to a manageable level. So that's kind of one focus, and then the other focus is going to be on the reduction of inflammation. So there's a few different medications that we use, and if you look on chart 18-9 on page 322 in your book, it'll show you those meds. So the first class are NSAIDs, and you know about NSAIDs already. These are to help reduce inflammation. They don't prevent the progression of the disease, but they can help to alleviate the pain and some of the swelling. Just remember that long-term use of NSAIDs can cause some GI distress and bleeding. It can also lead to impaired renal function. So one thing that we do to help protect the patient's stomach so they don't develop like a GI bleed is to use PPIs or H2 receptor blockers like ranitidine. We also have DMARDs. So DMARDs are disease-modifying anti-rheumatic drugs. And this class of medication is the most prescribed. It has an immunosuppressant property. And so what are some, anytime we're suppressing the immune system, whether it's with DMARDs, with corticosteroids, anytime we're doing that, we really want to be encouraging things like hand hygiene, daily temps, reporting any feelings of unwellness, getting flu shots, vaccinations, all those things to help to prevent potentially transmitting a disease that could really knock a person out if your immune system is down. So DMARDs, though, back to those, we've got some synthetic ones like methotrexate. These are big drugs, though, and so we have to be careful with them because they have a lot of side effects. They can do things like suppress bone marrow, cause hepatotoxicity. So then we want to make sure we're watching liver and kidney functions. Patients taking methotrexate should not drink alcohol, right? We also have biologics, which is this new class of DMARDs, and so that includes things like Humira or Enbrel. But these are expensive, and they do put the patient at an increased risk for infection as well. Then there's corticosteroids. So we can use corticosteroids or glucocorticoids like prednisone to help with inflammation as well. They also can suppress the immune system. We can do them either as a pulse therapy, which is like a short-term higher dose, or over the longer term as a lower dose. As I already mentioned, pain management and reduction of inflammation are two of our big goals with RA patients and treatment. We also want to increase ADL function because RA can become debilitating in time. We want to improve that as well. So some different non-pharmacological interventions that we can do and teach our patients to do is ensure that they get adequate rest, right? So they're going to want to space activities out. They're going to want to kind of prioritize, right? If they've got a bunch of things to take care of in the day, they have to figure out what's most important and kind of do that first. Maybe that means delegating responsibilities to family members if it's things they can't take care of. They should balance activity with rest. So taking a nap or two every day is important. Also pacing themselves, be realistic. It's important that they're honest with themselves so they know what their limits are, and then they can kind of plan accordingly. There's some different interventions, different things that we can do like range of motion exercise. That's super important in our patients with RA. We want to make sure that they're moving their joints around, even though it might be a little bit painful. It can really help to ensure that they don't lose mobility. We want to make sure too that we are encouraging muscle strengthening. So they can do things like light weights, or water aerobics is great. We want to be careful of high impact activities, things that could hurt their joints. But for sure, like yoga and other range of motion exercises are great. We can use heat or cold to put on the affected areas, and if you're using cold, we want to just make sure it's not something really heavy. So what a lot of patients do is just use like a bag of frozen peas or frozen corn to put on their joints when they're feeling really warm and swollen and painful. We never want to massage, though, a patient, right? That could actually cause more harm to them. They can utilize some complementary and integrative health, things like acupuncture, hypnosis, imagery, music therapy, all kinds of things. Something to think about too in our patients, and another reason, not only do we want to encourage exercise just to keep range of motion, but think about patients that are obese and all that extra weight, that extra pressure that is then going onto joints. So we want to encourage our patients to maintain a healthy weight as well, which will make it a little bit easier for them to get around. Energy conservation, as I said, super, super important. And then we also might need to involve occupational therapy, right? So if patients are having changes in their joints, we might want to involve OT to come up with maybe adaptive silverware, cups, things like that to make ADLs accessible for these patients and to keep them independent. They're going to probably need changes, modifications to their home environment in time. So things like a raised toilet seat, grab bars in the shower. Maybe they can't have a bathtub anymore. They just need a walk-in shower so they don't have to lift their legs up over the side of a tub. Lots of considerations. And then there's a lot of psychosocial stuff too, right? So this disease affects every aspect of their life. It's chronic, they're in pain, they can't do the things that they used to do. So there's lots of adjusting and loss that comes along with RA. Sjogren's syndrome is closely associated and can be a complication of rheumatoid arthritis. So just a reminder, I don't know if I've made it very clear, but RA affects the synovial fluid, but because it is systemic, it can affect any connective tissue in the body, right? Like blood vessels, the pleura around the lungs, the pericardium, and then the iritis and scleritis, which can happen in the eyes. So any connective tissue is fair game. In Sjogren's syndrome, what we see is this triad of symptoms. So we see dry eyes, we see a dry mouth, or a decrease in salivation, and a dry vagina as well. It's caused by an obstruction of the secretory ducts and glands in the body. So how we treat it, we give them artificial tears, artificial saliva, right? Because a dry mouth can lead to problems with your teeth, right? Cavities. Dry eyes can lead to irritation. So we treat it with that, and then we also want to encourage fluids with meals, just to increase just overall fluid in the body. Systemic lupus erythematosus, or SLE, or just lupus, some people call it, is this severe autoimmune disease. It doesn't have a very clear etiology, but again, we think there's contributing factors like genetic predisposition, hormonal influences, and then different medical irritants. But it's a chronic, progressive, inflammatory connective tissue disorder. It causes major body organs and systems to fail. So that's pretty serious, right? It can be life-threatening, but some patients have milder versions. What happens, so we have these anti-nuclear antibodies, or ANA, that affect the DNA and RNA in the nucleus of the cell, which leads to these immune complexes that form in the serum and organ tissue. and that those immune complexes cause inflammation, and inflammation causes damage to tissues. So when vessels are inflamed, organs don't get what? Oxygenated blood, right? So then the organs are damaged. For whatever reason, a lot of the autoimmune complexes in SLE tend to be really attracted to the glomeruli of the kidneys. So a lot of patients have some kind of kidney involvement, and oftentimes this is the leading cause of death in patients with lupus. But again, it's relatively rare, and it does seem to affect younger women, so women between the ages of 20 and 40. It's hard to just give one picture of lupus. It can look different clinically from patient to patient. There's this extreme range of symptoms. Sometimes too, when people are in remission that have lupus, they're healthy and they don't really have any activity limitations. But when the disease flares, sometimes patients get so sick that they have to go to a critical care unit. So again, this huge range, but just some of the things that you might see are polyarthritis, so it can definitely affect joint inflammation, multiple joints even. It can cause polyarthralgias, which is just pain in many of the joints. As I mentioned earlier, it affects the kidneys, so we see things like nephritis. We can see lethargy. They're just super tired, weak. They have a lot of fatigue. Patients can have a fever. We might see weight loss. There's some anorexia, abdominal pain there. And then there's some skin manifestations as well. So there's these really common inflamed red rashes that we see. A lot of times they happen over the face, and it kind of forms a butterfly, like you can see in the picture in the bottom right here. Their skin also, though, can become fibrotic, sclerotic, swollen. So lots of things that can manifest in terms of SLE. A lot of the labs that we do are similar to those with RA. And anytime we have a patient with glomerulonephritis, we should maybe suspect that they have SLE. In glomerulonephritis, the basement membrane of the kidneys, because the basement membrane of the kidneys is vulnerable to tissue damage in SLE, that's why we see this glomerulonephritis. The patient, we can do an ANA titer, and remember, anti-nuclear antibody, ANA, are just the antibodies that are produced by a person's immune system when it fails to adequately differentiate between itself and non-self. So that's what autoimmune disorders, right? So it targets, again, the substances that we find in the nucleus of the cell and causes organ and tissue damage. So we would expect to see an elevated level in patients with SLE, and we do 99% of the time. Interesting little tidbit here, don't worry about this for the test, but a lot of times patients with SLE have a false positive syphilis test, which is curious. We want to do CBCs though too, because we actually expect to see pancytopenia. What is pancytopenia? That's a decrease of all cell types, probably because there's this attack of blood cells or bone marrow, where blood cells are made by these different immune complexes. So we want to check electrolytes, kidney function, cardiac, liver enzymes, clotting factors, all these things. Because it affects the whole body, we need to be checking in to just see what kind of damage has been done. Medications that we use in lupus are things like steroid therapy, right? Steroids suppress the immune system, which keeps the body from attacking itself. They also help to decrease inflammation. We use topical cortisone sometimes to decrease the skin lesions and rashes that patients with lupus can develop. Sometimes we use NSAIDs to help with pain and inflammation. Methotrexate maybe to help with immunosuppression. There's a medication that's a biologic or DMARD that's specific to lupus called belizumab or Benelist, which can be taken as well. Sometimes patients are prescribed hydrochloroquine, which is an anti-malarial drug actually, but it helps to decrease the UV absorption by the skin, and so that can help to decrease the skin lesion development. There's some important information though with this drug. The patients have to do a routine eye exam, so every 6 months, because this med can cause retinal damage. And if the patient, or if they go in and their eye doctor does detect any changes in their retina or in their eye at all, then they do discontinue the medication. So we have some important teaching points here. We want to make sure our patients understand how UV exposure can make their disease worse and how sensitive they are to it. So we want to make sure that they're protecting their skin, things like wearing long sleeves, wearing hats, using an SPF of at least 30. We also want to promote the balance of energy, right, and energy conservation. So we want to encourage energy, but we want to make sure that they get enough rest in between. And then if they're having an exacerbation, they really just need to focus on getting better, so they should avoid activity during that time. Remember too, they're at a risk for an increased infection because of the immune suppressing medications that they're taking. So fever, right, is a major sign of infection in SLE, so we have them take their temperature frequently. We can monitor white blood cell counts and any other signs of infection, right, like diaphoresis, which is sweating, chills, that type of thing. The other thing to protect their skin is we can teach them to use things like gentle soap, moisturizers. Sometimes they're at risk for hair loss, and so there's gentle shampoos that they can use for that as well. Sclerodema, or systemic sclerosis, is a rare but chronic autoimmune disease where the connective tissue has this excessive collagen deposits, and there are also changes in humoral and cellular immunity. So this leads to inflammation, right? And sclerodema actually means hardening of the skin, but really that's only one symptom. In the localized version, the skin is mostly affected, but there's also systemic, where multiple organs are affected. It can lead to edema all over, which can affect the face, the extremities. The skin can lose its elasticity. There's a decrease in range of motion. Ulcerations can occur. Contractures can occur in the joint. So it's really a systemic problem. So what do we use to treat it? Well, we use systemic steroids. And remember, whenever we are using systemic steroids, we want to watch for immunosuppression, right? We also do use sometimes immunosuppressants in high doses. There is a newer class of drugs called endothelin receptor antagonists. One of them is called bosentan, and that is a med that can be used to treat systemic sclerosis as well. This slide just shows some of the limited signs and symptoms, and there's an acronym, CREST. So C is calcinosis, and as you can see in the fuzzy picture here, there's actually these calcium deposits that form in the skin. R is Raynaud's phenomenon, and we talked about that, where the small arterioles constrict, usually in response to cold or stress, and that can actually end up, it's painful, right? It can lead to things like amputation, though, of the digits because they're not getting adequate perfusion. So we want to make sure that we're keeping our patient warm, right, minimizing stress. The E is esophageal dysmotility or dysfunction, and that causes acid reflux. It leads to GERD. It also leads to a decrease in the motility of the esophagus. So things, we have to worry then about dysphagia. We have to worry about aspiration. It can lead to ulcers in the stomach, and then problems with absorption too, right? The patient's not getting nutrients if they're having trouble digesting. And then there's sclerodactyly, which is the thickening and tightening of the skin in the fingers and the hands, and we see that a lot where it's actually, they become so swollen they are described almost as sausages, and it happens later on in the course of the disease. And then lastly is this telangiectasis or dysaceus, which is these red marks that pop up on the surface of the skin as a result of the capillaries dilating. So they're almost described as spider-like. HIV disease is caused by the human immunodeficiency virus, or the HIV virus. It is a really, really common disease, and what can happen in time is that it progresses to acquired immune deficiency syndrome, or AIDS. And so what you can infer from just the name is that it affects the immune system, right? It's very, very common. 37 million people worldwide are living with HIV, and 1.2 million in the US. The thing about it is 20% of people are unaware that they have this diagnosis, and it is highly transmissible, so it is a worldwide epidemic, right? At this point, we don't have a cure. And the morbidity and mortality is really high in patients that are not receiving treatment. But if we can get patients to adhere to treatment, then they're able to live a long, healthy life. The HIV virus is an intracellular parasite. It needs to use the infected cell's resources to reproduce. So what it does when it gets into the body is it acts in a couple ways. One, it targets the CD4 plus cells of the immune system, and those are like the T helper cells, or the helper T cells. CD4 is a type of protein or antigen on the surface of the helper T cells. So remember, an antigen is kind of like the cell's name tag. It lets every other cell know what it is. And so CD4 is on the surface of helper T cells. In healthy cells, what they do is they tell other immune cells in our body, they alert other immune cells to pathogens. So they're kind of like the town crier. Because though the HIV virus attacks these cells, the immune system basically becomes useless. So when HIV gets into the white blood cells, it attaches to a protein called the GP120 on the cell's envelope, and the co-receptor, it's the CXCR4 on T cells, CCR5 T cells and macrophages. But anyway, it gets into the cell. So don't worry about all of that. Just know it gets into the cell, and then it has to have access to both the GP120 and the co-receptor to get into the cell. This is important for medication purposes, but it hijacks the cell's machinery, and it starts to insert its own RNA into the host cells. So it basically makes copies of itself. So this is how the viral load is increased, or the amount of the HIV cells in the body. HIV, though, it's not perfect. It does make some errors, and it can make different strains. So this is why we see these twofold. One, the decreased CD4 T cells, and two, an increase in the viral load. And note too, it's on the slide, but the viral load can replicate up to 10 billion new viral particles every day. So that's pretty significant, right? That's a lot of new viruses, particles being made. In clients that are affected with HIV, you can find the HIV virus in blood, semen, vaginal secretions, breast milk, amniotic fluid, urine, feces, saliva, tears, cerebrospinal fluid, lymph nodes, cervical cells, corneal tissue, and brain tissue. So most fluids of the body, right? The highest rates of transmission, though, occur in semen, blood, breast milk, and vaginal secretions. The others are really only common if there's also blood present. So let's talk about risk factors, and most of these should be pretty well known. But some patients still, they just don't have that education. So we can have, it can be transmitted through genital, anal, or oral sexual content when there's exposure of mucous membranes to infected semen or vaginal secretions. So in North America, it's most often caused by men who have sex with men, although it can be transmitted via heterosexual contact as well. In fact, 25% of new cases of HIV are women. There's the parenteral risk, right? So sharing of needles or different equipment that's contaminated with infected blood, or if you're receiving contaminated blood products. This used to be a bigger issue, but now donated blood products go through extensive testing to rule out the presence of the HIV virus. Sharing needles in either gender is a very common route of transmission. And then the third way is perinatal, so from the placenta, from contact with maternal blood and body fluids during birth, so there's a risk there too, or from breast milk from an infected mother to child. So we want to make sure that we're providing education about the transmission routes and ways to reduce exposure, but also know that HIV is not transmitted by casual contact in the home, at school, or at work. So things like sharing household utensils, towels, linens, toilets, you can't get HIV from that. It's not spread by mosquitoes or other insects. I just want to go back to the perinatal transmission. So the risk for transmission to infants from pregnant women with HIV who are not using the HIV drug therapy is about 25%. So it's not that every woman who is HIV positive and pregnant is going to pass that virus along to her fetus, but there's a 25% chance. If the mother, though, is taking antiretrovirals, then the risk goes down to 8%. So it's very, very important that we're encouraging HIV positive women who are pregnant to continue therapy, or if they're not on antiretrovirals, then they should start right away. There are 5 stages of HIV disease that the CDC has defined, the Centers for Disease Control and Prevention. And so when we have these different definitions, we use labs. So it has to be confirmed, right, that they have HIV, and we'll talk about that in a minute. So it's that and the presence or absence of these 27 AIDS-defining conditions. And you can find that in Table 19-1 on page 340 in your book. And I want you to take a look at those and really, really understand them. What these AIDS-defining conditions are just... the AIDS-defining conditions are these opportunistic infections, right, that typically we don't see in healthy individuals, but in people with HIV, their bodies can't defend themselves, so we see these diseases. And these are things like bacterial infections, candidiasis, all over the body. That one's super common, so know that. Cervical cancer, they can develop herpes simplex pretty easily, something called Kaposi's sarcoma, different lymphomas. They're more at risk for mycobacterium, pneumocystis, pneumonia, so that's really common as well. They can catch salmonella a lot easier. Toxoplasmosis, so many different things that they could potentially be exposed to. But let's talk about the stages. So an adult with HIV know that they can transmit the virus to anyone at any disease or any stage of the disease. But people, like, right away, the viral load is really high as it enters the body and it's replicating quickly. And then at the end, stage 2, without drug therapy, where viral load is super high as well. So stage 0 is for patients that just are diagnosed. So it has to be, it's after they've had a negative HIV test in the past, they've had their first positive HIV test, and it's for the first 6 months. So anyone, even if they meet the criteria for stage 3, they have to start at stage 0 for 6 months. Then you can go up to stage 1, which is a CD4 plus T cell count greater than 500 cells, or a percentage of 29% or greater. And that 29% is just talking about the number of the CD4 plus T lymphocyte percentage out of the total lymphocytes. So we're talking 29% or more. And at this point, too, they don't have any age-defining conditions. Stage 2 is a CD4 plus T cell count between 200 and 499. Percentage between 14 and 28, so the percentage and CD4 cell counts are going down, and they still don't have any of the age-defining conditions. Stage 3, though, so then there is documentation of an age-defining condition, as well as a CD4 plus T cell count that's less than 200. But know that having an age-defining condition is a bigger sign here. And at stage 3, then they are classified as having AIDS. And then there's also unknown stages as well. where we don't have any information about their CD4 plus T cell counts, the percentages, or the age-defining conditions. Note too that the normal CD4 count in a healthy individual is between 1,000 and 1,100. So HIV exposure. There are some pre-exposure prophylaxis methods that we can use in uninfected adults with the purpose of preventing HIV. And we use these in a very select high-risk population. So men who have sex with men, heterosexually active men and women, injecting drug users, those in serodiscordant relationships. And serodiscordant means that one partner is HIV positive, one's HIV negative. They take medication once a day, the Truvada, and they just take it once a day. It doesn't protect them against developing the disease 100%. They're still at risk, but it reduces their risk factor. So they do need to still practice safe sex practices. Also, it can't be given if somebody has active Hep B, because they are going to need to have ongoing renal function and HIV tests done periodically, so at least every 3 months or so. For healthcare workers, occupational exposure is contact between blood, tissue, or selected body fluids, right? Like cerebral spinal fluid, pleural fluid, synovial fluid, peritoneal fluid, pericardial fluid. I could go on and on and on. From a patient who is positive for HIV. And the blood, broken skin, or mucous membranes of the healthcare professional. So body substances that aren't considered infectious for HIV, unless they're like really obviously bloody, are things like feces, nasal secretions, sputum, saliva, sweat, tears, urine, and vomit. So they do not require prophylaxis, unless they're very visibly contaminated with blood. So what happens if you get stuck? Know that a percutaneous needle stick with a hollow bore or solid needle is the most common reason that this prophylactic therapy is needed. Other common exposure, though, is like if fluid splashes up into your eyes or your nose or your mouth. For sharps, what you want to do first is kind of bleed the wound, so kind of get push the blood out. Then wash it really, really careful for at least a minute, and then immediately contact your employee health. Or sometimes if it's outside of their normal hours, usually they have more business type hours. So if you're working evening or nights, they might be gone. So then you should call the ED and begin the documentation, testing, and the prophylaxis process. Note too that the risk goes up if you see blood on the instrument that causes the injury. So if you're a needle, for example, that has blood on it already, it increases your risk, patient blood on it. Or if you use a hollow needle like an IM or a sub-Q needle, because that hollow space inside the needle can act as a reservoir to hold patient blood. So once you're exposed, or if you're exposed, you do need to act fast, as I said. You've bled the wound, you've washed really well for a minute, you've contacted employee health. So then what they're going to want to do is test you right away. And doing an HIV test immediately does not tell you that incident that just occurred, that you contracted the virus through that. Instead, it rules out any pre-existing HIV. Then you're going to need to get tested again, because it takes a while for the antibodies to build up in the body. So we usually do a test again 1 to 3 months, and then up to 6 months later is a third time. And that's if the rapid test is positive. You're going to get started too if it's positive on the 3-drug CART therapy. And so CART just stands for combined antiretroviral therapy, where we're using this combination of medications. And it works the best. The best results are seen when you start taking that therapy within 2 to 76 hours of exposure. And then you take that for 28 days or until the HIV status of the source is determined negative. Because remember too, we do these kind of quick tests, or we can do more extensive testing, and that we'll talk about this here on another slide. So the clinical manifestations early on kind of resemble mono. There's really nothing that's super specific to HIV during this time. So what we want to do then, I mean, things that you will see are chills, fever, malaise, which is just like feeling really tired, having a sore throat, maybe they're nauseous, have a rash, have a headache. And then as the HIV disease progresses, then we can see more symptoms and potential serious health problems. So things like chills, fever, night sweats, cough. I mean, you can read these. Just the body is trying to fight off something that's attacking itself, right? Later on, opportunistic infections take hold, and so these are those infections that most healthy individuals are able to overcome, but because in HIV our immune system is so compromised, they're just not able to. And so examples are like the P0VC pneumonia, or the PJP, tuberculosis, the cytomegalovirus, shingles, all those things. So how do we test for HIV? Well, right away they'll do a rapid test, and this is something if you suspect you have HIV. And I should go back. The recommendation is that everyone 13 and up gets tested at least once, and then the at-risk people that are in at-risk populations or participating in risky behaviors should be tested more frequently. If there are different methods, you can go in and do it at your clinic. You can also do rapid home tests, or there are special walk-in clinics as well. They take 15, 60 minutes. Sometimes you get a call back later that day, but they're quick, and they're just reactive. They just tell you yes or no. You still need to do the more extensive testing after that for confirmation. And those extensive lab tests can take a little bit longer to get results. We'll talk about that in a second. So one thing that we want to monitor then is their lymphocytes, right? We're going to do CBCs and differential, look for things like anemia, thrombocytopenia, leukopenia, or low white blood cells. We're going to look for platelet levels that are maybe decreased to less than 150,000. We can monitor the CD4 T cell count. So again, in most healthy adults, it's between 1,000 and 1,100. It drops, we'll see, during the initial infection, and then depending on the course of the medication. We can also measure the CD4-8 T cells, and we look at the ratio between the two. So CD4-8 or CD8 T cells stay the same. CD4s drop. So the normal rate is 2 to 1. It's lower in HIV, patients with HIV. We can detect the actual HIV antibodies 3 weeks to 3 months after they're first infected, although some strains can take as long as 36 months. Measuring antibodies, though, is an indirect test for HIV. If a result has that positive test for antibodies, it doesn't mean that they have HIV or AIDS, only that they've been infected with the virus. So then we do these enzyme-linked immunosorbent assays, the ELISA, or the Western blot analysis. And those are third-generation tests that measure the HIV IgG antibodies. It used to be the gold standard. It's highly accurate, but it's incredibly time-consuming, and it can take up to 28 days to get that confirmation. More recently, we have these fourth-generation HIV assays, and those can detect the IgM-IgG antibodies within 21 days. They can also measure the P24 antigen, which is that HIV capsid protein in serum, in 14 days. So that's quite a bit faster. We can also test viral load. So that's another thing that we kind of monitor, is how many HIV particles are present in the body. And we measure particles per mil of blood. So uninfected would be 0, and we can measure as few as 40 particles, although high viral loads can be greater than 80,000 HIV particles per mil. Just remember, too, it can take some time for HIV to be detected, and the criteria used to establish an actual AIDS diagnosis is having a CD4 plus count less than 200, or having a variety of AIDS-defining illnesses or opportunistic infections. There are some videos in the speaker notes under this slide that talk a little bit more about CART therapy, one in depth, and then one is just kind of a light summary. So if you want to learn more about that, check it out. Your book also goes into a little bit more depth. So HIV medications, we take an approach that's called CART, which is combination antiretroviral therapy. Antiretroviral therapy does not kill the virus, it only prevents it from duplicating. So when we use only one antiretroviral or monotherapy, it promotes drug resistance, right? So we used to treat patients with highly active antiretroviral treatment, which is also a combination of antiretroviral drugs, and this is the preferred method of avoiding development of resistance. So we use combination now, which is a bunch of them. If patients take their medications correctly, they can actually cause their viral load to drop below detectable levels, but they have to be taken correctly 90% of the time, and they have to be taken correctly. So there's a bunch of different medications here that patients can take. They can take nucleoside reverse transcriptase inhibitors, which interfere with the virus's ability to convert RNA into DNA. They can take non-nucleoside reverse transcriptase inhibitors, which inhibit the viral replication. There's protease inhibitors that inhibit an enzyme that's needed for the virus to replicate, and so on and so on. So all these meds basically just interfere with the duplication in one way or another. So resistance, let's talk about that. Resistance is caused by things like missing a dose, putting a dose off, delaying the dose. If you take a dose that's lower than what's prescribed, all those things can lead to resistance. So just remember the 90% rule. There are some tests that can be done to see what strain of HIV has developed resistance to certain drugs. So in the body, if you've taken that drug and you have the strain, you have that resistance, then it never goes away. So the patient can never use that drug again, even years down the road. So it's very important. What are some drawbacks to CART therapy? Well, the medications are expensive. They have significant side effects like diarrhea, nausea, loss of bone density, and there's a lot of drug interactions, like they interact with antacids and St. John's wort. There's food and timing requirements. There's a number of daily drugs, although there are a lot of combo drugs now that have been developed, minimizing or reducing, I guess, the number of pills they have to take. But this is lifelong, right? So it is challenging for patients, and it's a cumbersome process. A client is diagnosed with AIDS who is receiving combination antiretroviral therapy, who now has a CD4 plus T cell count of 525. How will the nurse interpret this result? All right, so we would interpret this as being effective, right? A client who is diagnosed with AIDS meets the criteria, then they're at stage 3 in the stage 3 category of HIV infection. So even if their CD4 count goes up because of therapy, they still have that AIDS diagnosis. That does not go away. The fact that the T cells are up tells us that the combination of drugs is effective, right? That doesn't mean, though, that we decrease the drugs. A nurse is preparing a client with systemic lupus erythematosus, SLE, for discharge. What instructions would the nurse include in the teaching? Select all that apply. So please put me on pause, and then we'll talk. All right, so number 1, stay out of direct sunlight. Yes, so just a reminder, SLE is a chronic autoimmune disease. It can damage any part of the body, the skin, the joints, any organ. Because it damages the skin, we want to teach our clients to stay out of direct sunlight and avoid other sources of UV light, because they actually might trigger severe skin reactions and exacerbate symptoms. We also would select number 3. So number 1 is correct. We'd select number 3, monitor body temp. Client's body temp would be monitored, and we report fevers to healthcare provider. 4, taper the corticosteroid dose is prescribed when symptoms are under control. Yes, so we always taper corticosteroids gradually once symptoms are relieved, because if they stop the drug abruptly, it can cause adrenal insufficiency, which is potentially life-threatening. Prolonged use of prednisone can damage the adrenal glands too, which cause them to shrink and stop producing cortisol. So when you stop abruptly, the glands aren't able to prepare by producing enough cortisol. So that's why we see these withdrawal symptoms, which include vomiting and shock. Do not limit activity between flare-ups. So that's right. Fatigue can cause a flare-up, so we pace activities, right? We plan for rest. Also, the client should apply heat and not cold to relieve joint pain. Cold packs can aggravate Raynaud's phenomenon, which happens a lot in our clients with SLE. A nurse is planning care for a client with HIV. The RN is delegating responsibilities to an LPN/VN. Which statements made by the LPN/VN indicate an understanding of HIV transmission? Select all that apply. So just remember, as the nurse, when you're delegating to a VN, LPN, it's important that they understand the client's condition and also the task that you're delegating. So when we're caring for a client with HIV, standard precautions includes wearing gloves for any known or anticipated contact with blood, bodily fluids, tissue, mucous membranes, or non-intact skin. If the task may result in splashing or splattering of blood or body fluids, then a mask and goggles or a face shield and a fluid-resistant gown or apron would be worn too. We'd also always want to wash our hands before and after client care, and after we take off our gloves. So the answers here are what? 4 and 5, right? So we don't need to wear gloves for everything. They should be wearing personal protective equipment. Nurses have a huge occupational risk. And then we don't have to wear a mask if the client has a cough due to upper respiratory infection, because that is specific to respiratory infection and not HIV transmission. A nurse is caring for a client with moderate RA. Which non-pharmacological interventions would a nurse include in the plan of care? This is a select all that apply. All right, so rheumatoid arthritis is a chronic systemic inflammatory disorder. It affects many tissues, organs, and joints, right? But in particular, the synovial fluid. So supportive non-pharmacological measures include applying splints to rest inflamed joints, using Velcro fasteners on clothing to help with dressing, and applying moist heat to joints to help to relax the muscles and relieve pain. Inflamed joints would never be massaged because doing so can aggravate inflammation. And a PT program including range of motion, exercise, and individualized therapeutic exercises helps to prevent loss of joint function. Assistive devices would only be used really when marked loss of range of motion occurs. So the answer here is 3, 5, and 6.